Dr. Ichiche, and I'll be taking practice question 1A. A 53-year-old man with background hypertension, type 2 DM, previous duodenal ulcer, treated 10 years ago, developed a right DVT 2 months ago, and on tab warfarin 5 mg Nocte. He returned from a business trip with central chest pain radiating to the neck, jaw, and back. History of fever a week prior to presentation. Is obese. Blood pressure on the right hand is 125/75 millimeters of mercury, and on the left hand is 135/70 millimeters of mercury. Number one, mention 4 differentials. Number 2, what investigations will you do? Number 3, CS ECG showed sinus tachycardia, ST segment elevation in V1 to V5, pathological Q waves in 2-3 AVF, and ST segment depression in 2-3 and AVF. Question 4, what's your likely diagnosis now? Question 5, mention 3 abnormalities in the ECG. Question 6, how will you manage? Question 7, there's no PCI in your center, and you decide to give this patient streptokinase infusion for thrombolysis. Subsequently, develop blood pressure of 86/40 millimeters of mercury. List 3 causes or reasons of hypotension. And the last is list other complications of MI. So for question 1, mention 4 differentials. The very first differential will be acute myocardial infarction. And the diagnosis of acute myocardial infarction is based on when two out of the following criteria are met. When the symptoms of ischemia, the central chest pain, which these patients had, radiating to the neck, jaw, and back, the new ST segment changes or a left bundle branch block. Then when there's presence of pathological Q waves on ECG, new regional wall motion abnormality, and presence of an intracoronary thrombus at autopsy or angiography. So these patients met 2 of these criteria, that is the symptoms of ischemia and then the new ST segment changes, 3, as well as presence of pathological Q waves on ECG. The risk factors, the non-modifiable and the modifiable, that's the sex, age, family history, male pattern hair loss. Then modifiable, smoking, elevated LDL, hypertension, obesity, sedentary lifestyle, peripheral vascular disease, elevated levels of homocysteine, oral hygiene. These patients met both non-modifiable, meaning that this age, sex, male sex, the history of obesity, the history of type 2 DM, and okay, other differentials would be acute pulmonary embolism, because of the chest pain, is obese, history of DVT, recent travel, though it wasn't stated if it was a long distance travel, but it's still a stressful event, as well as other risk factors. Then other differentials are dissecting aortic aneurysm, issue of hypertension, chest pain, disparity in blood pressures, and other risk factors. Other differentials are acute pericarditis as a result of the presenting complaints of fever and chest pain, community-acquired pneumonia. These are all others, but the first 4 I would go with are acute myocardial infarction, acute pulmonary embolism, dissecting aortic aneurysm, and acute pericarditis. So number 2, what investigations would you do? Investigations I'll do for this patient, I'll check his SpO2. I'll also do serial ECGs, which is highly specific. And the ECG findings are ST elevation greater than 2 millimeters in 2 contiguous leads on ECG. There's inferior leads 2-3 AVF, the septal leads V1, V2, the anterior leads V3, V4, and the lateral leads lead 1, AVL, V5, and V6. And these are all indicative of a STEMI. I also do an echocardiography for this patient, the cardiac biomarkers, troponins, INT, CKMB, and LDH. I also want to do cardiac imaging, especially like a cardiac angio. This is used to perform PCI or determine obstruction in the coronary vessels. Also, since the patient is living with diabetes, I want to do an urgent random blood glucose at presentation, and as well as the daily fasting blood glucose and HbA1c. I also want to do a CT pulmonary angiography, chest radiograph, Doppler ultrasound, D-dimer, AUC, uric acid, arterial blood gases, full blood count, ESR, urinalysis, lipid profile, and serum homocysteine. Okay, we were presented with an ECG. We were given an ECG which showed sinus tachycardia, ST segment elevation, in V1 to V5, pathological Q waves in 2-3 AVF, and ST segment depression in 2-3 AVF. What's your likely diagnosis now? Okay, I'll go for ST segment elevation. That's an anteroseptal MI, as well as an old inferior MI. Then the next question is, please mention 3 abnormalities in the ECG above. In the sinus tachycardia, there's ST segment elevation in lead V1 to V5, pathological Q waves in 2-3 AVF. This information was given in the question. I will also expect to see ST depression in lead 2 and AVF. This patient is hypertensive. I also expect to see left ventricular hypertrophy, a left bundle branch block, and a prolonged QT interval. How would you manage? Now, the principles of management of this patient are: stabilize the patient, relieve the ischemic pain, and reduce myocardial damage, and prevent further ischemia. By way of managing this patient, I'll do the ABC of resuscitation, then admit this patient to the high dependency unit or the intensive care unit or the cardiac coronary unit. Now, management is multidisciplinary, involving the cardiologist as well as the nurses. Then it's important that serial ECGs and vital signs monitoring are done for this patient. The specific management is immediate reperfusion. But however, before that, I want to go through the more number that we know in the management of acute coronary syndrome. I'll give this patient oxygen, especially if the SpO2 is less than 94% for STEMI. Therefore, analgesia, I'll give the patient opioids, IV morphine boluses titrated to clinical effect, 2.5 milligrams to 5 as initial dose. Now titrate every 5 to 10 minutes with further incremental doses of 2.5 to 5 milligrams. Other alternative is fentanyl, 25 to 50 micrograms. Then antiemetics, IV metoclopramide, 10 milligrams. You want to give nitrates. This should be given by IV infusion, and this is indicated when the pain is not controlled by opioids. As well as acute, other indication, acute severe hypertension, acute angiogenic pulmonary edema. I also want to give patient antiplatelet therapy, aspirin, 300 milligrams stats, then 100 to 150 milligram daily. Then dual antiplatelet therapy is recommended in patients who are undergoing primary PCI for up to 12 months. The other alternatives are clopidogrel, ticagrelor, or prasugrel. So I also want to give the patient high-intensity statins, heparin or enoxaparin. If I'm giving them IV heparin, it's 5,000 units. The other alternative, enoxaparin, 1 milligram per kg. Since I'm going to give the patient heparin or enoxaparin, I will stop the warfarin of 5 milligram the patient was previously on. So I want to give patient beta blockers, oral or IV metoprolol, 5 milligram every 2 to 5 minutes. Then I'll treat comorbidities, which are type 2 DM and duodenal ulcer. I'll give insulin for type 2 DM and PPIs for duodenal ulcer. I also want to give patients 2 softeners. Then the other forms of management, glycoprotein 2B23 inhibitors, abcimimab, eptibatide, tirofiban. This is usually recommended at the time of PCI. Then reperfusion is indicated in all patients who present within 12 hours. And then the other treatment is PCI or emergency cabbage. So for this patient, it's a PCI that I would go for. Then for post-operative and rehabilitation care, it's important that cardiac rehabilitation plays a role in the recovery of patients following an acute MI. This improves the quality of life, reduction of disability, and decrease in mortality. I would counsel the patient to stop smoking, adhere to low salt diet to reduce blood pressure, as well as diet, alcohol, and weight control, exercise-based cardiac rehabilitation, blood sugar control, and counsel patients to remain compliant with medications. For post-ACL drug therapy and secondary prevention, patients would be on TAPS aspirin 75 to 100 milligrams daily, beta blockers, ACI statins, and in some cases, some patients may be given mineralocorticoid antagonists. And for question 7, list 3 reasons or causes of the hypotension. This patient was given streptokinase infusion for thrombolysis and had hypotension. So the reasons are streptokinase-induced anaphylaxis, failed thrombolysis, reinfarction, arrhythmias, and rupture of myocardial aneurysm. Now, the mechanism of streptokinase-induced hypotension is that there's a reduction in total peripheral resistance, there's complement activation leading to widespread arteriolar dilation, and activation of prostaglandin kallikrein system through factor 12 that is activated of activated by plasmin. And by way of treating this hypotension, I would consider withdrawing the streptokinase and place the patient in a high head-down position, give the patient intravenous normal saline position, and the specific treatment is aminocaproic acid, tranexamic acid, and protein. Then the complications of MI, which is the last question, is a new onset atrial regurgitation, ventricular septal rupture, left ventricular aneurysm, arrhythmias. These patients can have arrhythmias and emboli. The poor prognostic factors are diabetes, which this patient has, advanced age, patient is 53 years old, prior MI, peripheral vascular disease or stroke, delayed reperfusion, diminished ejection fraction, which is the strongest predictor of poor prognosis, and the presence of CCF, elevated CRP, BNP, and depression. Thank you.
Thank you so much, Dr. Chude, for that beautiful presentation. I kept the time too. Thank you so much. Okay, so now we'll take comments and questions. Okay, Dr. Kalamama, your hands are up. Okay, let's take the comments first.
Okay, thank you so much, Dr. Icheche. That was a beautiful attempt. I don't really have much to add, but just rearranging your principles of management. Okay, so basically, I think we'll start with resuscitation therapy. You actually mentioned everything, but it was everywhere. Okay, so the resuscitation therapy, that's where we do the ABC. Thereafter, you now go over to relieve symptoms. Okay, so you know this patient actually presented with pain. So as you said, we give morphine. But you know, morphine has emesis as a side effect. So you add on an antiemetic with the morphine to be given. If given the morphine and then the patient is still presenting with pain, then you now go to the nitrates. That's where you go to the nitroglycerin spray in that acute phase. Then over time, we now give the patient ranolazine for the chest pain because those are like vasodilators. It helps to increase perfusion to the myocardium. You know, the pain actually comes from ischemia. Okay, so thereafter, the next principle of management will now be reperfusion, because what this patient needs is perfusion because this patient has a STEMI. So in a place where basically what will happen there is I will do a percutaneous coronary intervention, but in hospitals where you don't have a cath lab, that's where you now do what you now thrombolize this patient. But in the end, this patient will need a PCI. Then depending on what you see, that is stent or a cabbage, just coronary artery bypass grafts. Depending on what you see, most times in diabetics they have multiple stenosis, multiple stenotic sites. So most times they benefit from coronary artery bypass and grafting. Then the next principle of management, I said the first one is resuscitation therapy. The second one is relieving symptoms. The third one is reperfusion. And then the fourth one will now be treating the comorbidities. This patient actually has DM. So you give either you're giving insulin, depending on what exactly insulin, or maybe giving those oral hypoglycemics and all. Then also the patient is hypertensive, we treat, but just that those other drugs we give to prevent further reoccurrence can still take care of the hypertension indirectly. Okay, so after treating the comorbidities, the next thing you will now do is that if there are any complications, you treat the complications. Then lastly, you will now write prevention of reoccurrence. Under the prevention of reoccurrence, that's where you talk about the lifestyle modification. That's where you talk about the anti-double platelets. You understand the double anti-platelet therapy. That's where you talk about the aspirin. That's where you talk about giving maybe clopidogrel or giving giving them vasoprine. You understand, like clopidogrel and then vasoprine, the double anti-platelet therapy. Then that's where you now have the beta blockers, the ACIs, the lipid lowering medications, and you can actually add on plus or minus mineralocorticoid receptor antagonists. So those are drugs that we actually give to prevent reoccurrence. So it's in that pattern, resuscitation therapy, relieve symptoms, reperfusion, treat comorbidities, if any, treat complications, if any, and then prevent reoccurrence. So that's the format we actually follow. So thank you so much. That's all I can add on. You did an excellent job. Thank you so much, Cheche.
Well, thank you so much, Dr. Kalama, for making it look so simple. Okay, Dr. Conte, please go ahead.
Yes, good morning, colleagues and facilitators. Thank you once again to the presenter for a very well, presented answer, well summarized. Just to comment on the one of the treatment options, given the beta blockers, we should always remember it's not routinely given to every MI patient. You have to take it in the context in which the patient presents. So if they have any hemodynamic instability or severe bradycardia, then you cannot give them the beta blocker. So if their blood pressure is normal and their heart rate is fine, it's very good to use because it reduces the oxygen demand to the heart. But it has to be used in the context of the patient. It's not a routine that you give. Okay, then the other thing, I want you to go to the other investigations that you were asked to do. So a patient with this presentation doing a non-invasive imaging, CTPA, for this patient would not be indicated, okay? Because this patient already has ECG findings of acute STEMI. So you obviously know there is obstruction to flow. So what you want to do if you have the facility is invasive imaging so that you see the culprit vessel and intervene. Going back to do a CTPA is like going backwards in the investigation when you already have ECG evidence showing that there is acute obstruction to flow with the ST segment elevation. So we have to take note of that. The non-invasive imaging in a case presentation like this is certainly not indicated because it's like you are going back in the investigation of the patient. Thank you.
Thank you so much, Dr. Conte, for the addition. Okay, so on the chat, Dr. Ojile, you have a lot of applause. Dr. Rita saying thank you for the presentation. Dr. Raga, Dr. Wakama, they're all applauding your presentation. Dr. Bashar says thanks so much. It's epic. Okay, Dr. Olalekon says good morning. Thank you for the presentation. The ECG finding is in keeping with anterior STEMI. That's this V2 to V5 rather than anterior septal STEMI. Okay, thank you, Dr. Olalekon. Then Dr. Araga says oral DM drugs shouldn't be an ideal choice. With this acute presentation, insulin will be preferred. We can use GLP-1 agonist in this index patient. He's obese. Thank you so much, Dr. Araga. Dr. Mahmoud is saying thanks. Dr. Light is saying thanks. So thanks so much for the beautiful presentation. Okay, I can't see any other hands up. It was a beautiful one. Thank you so much. So I'll hand over to our teachers now. Mark Christabel.
Hello, thank you so much, Dr. JD. Thank you. That was wonderful. Dr. Kalamama, Dr. Conte, thank you for coming in. I expected more interaction from the cardiologist, but I understand you guys are doing your convention or something, so maybe that could explain the silence, but I must appreciate the two cardiologists for speaking up. Dr. Fatima, our teachers, Dr. Fatima, Okopi, Chief Cookie, Chief Bansi, Chief Amigos. I don't need any comments from your end. Chief Chitu, any comments, sir?
Yeah, good morning, ma.
Good morning, Dr. Fatima.
Yeah, though I joined late, but I will say we have reliable cardiologists that always come in. I didn't listen to most part of the presentation, but I believe whenever you have a patient with STEMI, the first thing that should be done in an ideal setting before the patient, within 10 minutes of reaching the hospital, the patient must have had an ECG. Immediately after the ECG, if there is need for oxygen, that should be commenced. Then heparin, dual antiplatelet, and without wasting time, within 30 minutes, that patient should be taken for revascularization. Dot to needle, if there is no PCI center, that is time to thrombolysis should be within 30 minutes to revascularize either with streptokinase alteplase or tenecteplase. But if it's in a PCI center, then there is no need to waste time, but the patient should immediately have a coronary angio and then either stent or CABG, depending on the findings. But a patient with diabetes and STEMI, if he has at least 3 vessel disease or a left main disease is affected, then that patient should go for a CABG. So all other drugs are considered after the intervention, including the beta blockers, the ACIs, the spironolactone MRAs, as well as SGLT2, because recent findings have shown that even without diabetes, you need to give such medication. So this is my little contribution, but I heard Dr. Conte and Kalamama have made very good contributions. Thank you so much.
Thank you, Dr. Fatima. Thank you
you,
so much. Thank you. Any more comments from our teachers? Okay, Dr. Ujile, Dr. Atuni wants you to throw more light on CABG.
Yeah, CABG is a coronary artery bypass graft, which is a procedure that's done primarily for patients that have multi-vessel disease, and as well as patients who have risk factors. And it's a procedure that is actually used to improve blood flow to the heart. And it's usually indicated when the blood vessels are narrowed or blocked. For these patients, it actually involves taking blood from another part of the body, and such as the chest, the lower limbs, or the arm, and then attaching it to the coronary artery above and below the narrowed area or blockage. Now, that blood vessel is actually the graft. So this usually restores the blood flow to the ischemic area, and for patients that have a coronary artery disease, this procedure is usually used to do that, and it's usually is a very common procedure in places that have a cath lab. And before this procedure is usually done, there are some investigations that should be done, like pre-investigation, like the ECG, the echoes, stress ECGs, the angiography before this procedure is done. Also, the sorry, that's all I can go.
Okay, that's fine. Dr. Conte or Dr. Kalaman, the cardiologist, I don't know if you want to add any other thing.
Okay,
Dr. Conte,
just
go ahead.
okay. I can't
Okay,
help you
go
talk.
ahead,
No,
go ahead.
no, Dr. Conte, talk. Don't worry, talk.
Okay, yeah. So the thing I would love to add about that is that you know, when it comes to revascularization, you know, the first option we want to consider is PCI, percutaneous coronary intervention, because it is a minimally invasive procedure. So the safety is very good, you know, and especially considering patients present in this acute setting, you know, there's already the stress of the myocardial infarction. So you don't want to add the stress of surgery on top of that. So preferably the PCI is your first go-to. But however, there are certain cases wherein you have, depending on the type of disease you have, they cannot be amenable to PCI. And sometimes if you do attend PCI, you end up with catastrophic complications. So for instance, when you have a left main coronary artery disease, so if you have a disease of the left main vessel, so the whole of the blood supply to the left heart is at risk. So when you put a wire and try to deploy a stent there, you're going to momentarily stop blood flow to the whole of the left heart, and you can worsen the infarction and even get a cardiac arrest on the table. So those kind of lesions, we prefer to do coronary artery bypass surgery. And also in situations like, for instance, this patient is diabetic, so and they tend to have diffuse disease, multi-vessel disease. So as an indication also, when you have free vessel disease, okay, you cannot attempt to do those procedures with PCI because you can also seriously compromise flow to the heart during the procedure. So then we would refer such patients for CABG instead of a PCI. But otherwise, if there are no left main, no three vessel disease, then we want to do the less invasive procedure, which is associated with better outcome. Thank you.
Okay, thank you, sir.
Then just to add on to that CABG, like maybe the person does not understand what exactly it means. So basically what they do is that they take a vessel, like a large vessel, either the mammary, intermammary vessel or the femoral vessel. So what they basically do is that they cut off a particular part of that vessel, then go to the coronary vessel that is affected, cut off that stenosed part, and then anastomose, like the word grafting. So you're taking blood vessel from a larger blood vessel of the body, either the intermammary vessel or the femoral vessel. Then you go to that stenosed part and graft it there. So that stenosed part is cut off, and then you're now doing a grafting on that part that was stenosed, and you now do anastomosis. I don't know if I've been able to explain it well. Thank you.
Thank you.
Thank you so much, Dr. Kalamama, Dr. Conte. Thank you. I think you guys have done justice to that question. Doctor, I think there's another question about their D time. Dr. Ekele, can you read the question so that it can be attempted for on to the next question?
Okay, so what's the golden hour for thrombolysis or PCR and CABG?
It's within 30 minutes of arrival in the hospital. Then if there is no facility for PCI, I think it's 60 minutes. So the door to needle time, it's I think it's 30 minutes. I'm not so sure. But when the patients arrive in the hospital, it's patient should receive thrombolysis within 30 minutes, and then the time after the thrombolysis to the PCI or the CABG should be like 60 minutes. That's a total of 90 minutes, 90 to 120 minutes.
Okay, just to add on it, thank you so much. Door to needle time is within the first 60 minutes. Then door to balloon time should be within the first 90 minutes. Door to needle, 60 minutes. Door to balloon, 90 minutes. Okay.
Yes, hello. Yes, so just to put this whole timing thing into context. So the window of time to do revascularization. So you take from the time the patient had the chest pain, okay? From the time the patient had the chest pain on to 12 hours. That is your best time to do revascularization and get the best result. So from start onset of chest pain on to 12 hours. So either PCI or thrombolysis. Okay. Now, specifically for thrombolysis, you get your best results if you do the thrombolysis within the first 6 hours from the onset of pain. Okay. And then for PCI, if the patient presents outside the 12 hours, okay, but they are still having ongoing chest pain, and you can still do PCI up to 48 hours. You still have some benefit, although the benefit is not as good if you do it within 12 hours. Okay, so within the first 12 hours from the onset of chest pain is your time, PCI or thrombolysis. But for thrombolysis, your best bet will be within the first 6 hours. Okay, and then PCI is the first 12 hours, your best bet. Although in certain cases, you can extend up to 48 hours. Now, that is the overarching time to be able to save the myocardium. But then within the institution, there are other things, measures you can put in place to be able to improve this timing and get the patient within the time that you benefit the most. And that's the time you begin to talk about your door to needle time. So for the thrombolysis, so from the time the patient enters the door of your hospital, you want to make sure that you thrombolize them within 30 minutes so that you are able to stay within that first 6 hours when you get the best response. Okay, and if you are a center that is equipped with PCI facility, then once the patient enter your hospital, you want to have them on the bed and have the wire across the lesion within 60 to 90 minutes. Okay, so all those are things that you do in your institution now to be able to maximize on that timing within which you're able to save as much myocardium as possible. And then also, there's another timing also, if you are a facility that you cannot do PCI, but then there is a facility around you that is PCI capable. So if the patient presents and the patient can be able to move from your facility to the PCI capable facility within 120 minutes, within 2 hours, then you can actually refer the patient for primary PCI. But if they're going to take more than that, then you can thrombolize. You do now what is called the pharmacoinvasive method. You thrombolize the patient in your facility and then refer to get PCI within 24 hours. That has also been shown to be associated with good outcomes. Thank you.
Thank you, sir.
Thank you, Dr. Conte. Thank you, Dr. Kalamama and Dr. Ojiri. We appreciate you. Thank you so much. Dr. Keller, please confirm if there are any more questions or comments. So I'll move to the next question.
All right, ma'am. Okay, so there's a comment on the chat. So door to needle time, that from Dr. Necker. Presentation to thrombolysis is 30 minutes, and then dot to balloon time, presentation to PCI is 60 to 90 minutes. Thank you, Dr. Necker. Okay, so I don't think, okay, there are no more comments and questions. No comments and questions.
It's fine. Thank you so much. Thank you, Dr. Ojiri, once again. Dr. Conte, Dr. Kalama, thank you for coming to enlighten the class and making this question more interactive and with a lot of learning points. I appreciate you for that. Dr. Keller, thank you too. Please come move to the next question.
Okay, sorry, ma'am, please can you stop the recording first?